This video lecture completes the chapter on the urinary system by discussing the clinical aspects of diagnosis and treatment of kidney function. And so when we're worried that the kidneys are not working as properly as they should be, one easy thing that we can do is urinalysis, have our patient pee in a cup. And so when we have them pee in a cup, we will monitor things like the urine composition. We're going to take a look at specific gravity. Specific gravity refers to the density of urine. And so a pure water solution would have a specific gravity of 1. That would be our standard. And so whenever you add anything into a solution, the specific gravity gets heavier, the number goes up. And so for the average person, specific gravity, the average healthy person, specific gravity is usually going to be, oops, bear with me for a split second. Just realized I should have a little too far on my nose to help me make sure I say all this right. Is going to be somewhere in the area of 1.015 to 1.025. And so that's the normal specific gravity that we'll find in a patient. And if it's really dilute, really low, okay. Or if it's really concentrated, really high, okay. We need to figure out the why. And so if they're just very dehydrated, we would expect it to be very, very concentrated. If they're drinking lots and lots of water and just peeing out a whole lot really quickly, very low. Second thing we want to quickly look at is pH. Now, pH of blood, you learned, was 7.35 to 7.45, very narrow range. The pH of urine tends to run between 4.6 and 8.4, much wider range, which makes sense because remember, the whole point of urine is pulling stuff out of unfiltered blood to keep that blood in that 735 to 745 range. And so let's say you're working out hardcore all day Sunday, making a lot of lactic acid. You're going to draw that excess acid, dump it into the urine, you would have a very low pH. Makes sense. And so a wider range makes sense. Now, if it gets really low, that means your body has to work that much harder to maintain good blood pH. Something must be weird. And so we can check on that. Now, as far as composition of urine, two other things important to look at are pyuria, which is pus, and hematuria, which is blood. Obviously, we never want to see either one of those in urine. And so if we find pus or we find blood, we're looking at either an infection or we're looking at trauma. Two other things we normally do not see in urine are glucose and protein. And so if your patient has not done something weird, like suck down 16 Baby Ruths after hiding all the Halloween candy and not giving it out, yes, they're going to have a lot of glucose in their urine the next day. But other than that, the average person will not have measurable levels of glucose or protein in the urine. If it shows up, that should be a red flag. All right. We're also going to take a look at the volume of urine being released. And so we want to figure out how much are they producing? How much urine are they making? And so polyuria would be an increased production of urine. And so a person who is diabetic typically demonstrates polyuria. Diabetes actually in Greek means to travel across. The water is traveling across the kidneys faster than normal. Oliguria is a decreased production. This could be an example of dehydration. Anuria is no production. I don't care how healthy you are. Everyone makes pee. And so if you're not making any pee, then that tells me there's some serious obstruction in the urinary system. It's blocking you from being able to release any of that urine into the toilet bowl. And so we want to monitor to see if any of these abnormal levels of volume are occurring. Now, we can also measure kidney function from the blood side. So we can take a blood test. And so one blood test we can perform is the BUN, the blood urea nitrogen. Urea is a protein waste product. And so we deaminate amino acids as we break down excess amino acids. That ammonia group combines with carbon dioxide to make urea, which you then pee away. And that's the urea. Now, a healthy person, their BUN level will be very, very low, simply because you want to throw it away as quickly as possible. The PC value is your plasma creatinine. Creatinine is specifically a muscle waste product. And again, as muscles work out, they break up and make some of this stuff. Kidney throws it away as fast as possible. Healthy people will have low BUN and low PC. If the values are higher than normal, then either you're breaking down proteins faster than normal, or your kidneys are not getting rid of it faster than normal. And we'll have to do some further tests to figure out which event is occurring. While we talk about clearance, I also want to talk about something called the renal plasma clearance, the RPC value. The renal plasma clearance determines the rate of removal of a substance from the blood. Every molecule has its own unique RPC value. Glucose does, sodium does, potassium does, and so forth. And so it tells us how quickly something leaves the blood. As an example, if we look at something like urea, well, urea would have a very high RPC value. We want it gone quickly. On the other hand, albumin, that's one of those plasma proteins that helps to maintain good osmotic pressure. I want to have a very low RPC value. I don't want to get rid of my albumin. I want to keep it. Now, when you take a pharmacology class and you learn about different drugs, we have monitored and we know what the standard RPC value should be for any drug. And if you want a drug to be act quickly and leave quickly, you want to have a high RPC value. If you want that drug to go into the body and stay a long time, then you want to design to have a low RPC value. I remember when the ads first came out for Aleve. Aleve was this wonderful painkiller. Whereas instead of taking, 12 aspirin a day because my back hurts, I only take 2 Aleve because someone tweaked it chemically that it didn't leave so fast. It wound up decreasing the RPC value. So the medication stayed in the blood longer. This is important for you to know in pharmacology because you want to make sure your patient is not under-medicated or over-medicated. All right. Now, if your kidneys are not functioning well, okay, if things are not going well, you're going to pollute that blood really quickly. What can we do? Well, one of the things we can do is hemodialysis. Hemodialysis is an artificial kidney machine, and that's where we're going to draw your blood out of your body, and we're going to run it through a machine that acts like a kidney and filters out bad stuff and leaves in good. And so you can see a little diagram here, and this gentleman is having his blood pulled out through the machine at a dialysis center, and then it's cleaned and put back into him. It's very effective. It's very expensive. And you have to sit there in this dialysis center. My brother-in-law, living way up in northeast Montana, suffered he had severe chronic renal disease to the point that his kidneys were not filtering well enough. And so they would have to drive to Billings, Montana, which was the closest hemodialysis center. That was 5 hours away. And so they'd have to go there, spend the weekend. They'd filter out his blood, change his oil, and then he'd go home. Well, as he got sicker and sicker, you just couldn't keep driving back and forth all the time. Luckily, there's another process called peritoneal dialysis. Peritoneal dialysis, I find this fascinating. This uses the mesentery, that little semi-permeable membrane inside your abdominal cavity that helps to hold your intestines in place. That mesentery is a semi-permeable membrane full of blood vessels. So someone got the brilliant idea of putting a little indwelling catheter into the wall of the abdominal cavity and use a little pump about the size of a typewriter to draw a bunch of very dilute fluid and push it into the abdominal space. And then through just passive movement, waste will diffuse out of the mesentery into that fluid in the peritoneal space. And after about an hour, then the pump would change and would draw the fluid out and drop it down into a little drainage bucket. And so my brother-in-law would just take a nap, hook all the equipment up, and just lay there. And while it did, fluid would go in for a while and would pull out. And it would just pull waste out. It's not as effective as hemodialysis, but it's something that he could do at home. And it allowed him to be able to keep his blood healthy enough that they weren't having to drive to the dialysis center every other day. And so it gave a little bit more at-home control of his life. Hemodialysis and peritoneal dialysis both are just stopgap measures. You're not waiting for the kidneys to heal. You're just waiting till finally you get to be a proper candidate for kidney transplant. You're waiting for someone to provide a kidney that matches you. Now, you guys know that transplants are tricky because of protein matching, all that immune rejection. And you saw me draw the nephron. That's a lot of surface area where antibodies could notice something that doesn't belong. It's a real risk. Kidney rejection is very, very tricky. Knock on wood, I say a thank you for, and I say a prayer for the individual who had died in a car accident in Denver almost a decade ago. They were a protein match for my brother-in-law. And so their kidney was put into my brother-in-law, and they surgically placed it in, attached to the blood flow, attached to the ureter. Works like a charm. Does beautifully, does wonderfully. Now, in this case, the picture here shows where they removed the kidney. If a kidney is becoming necrotic, yeah, you do. But if the kidney is still functional, even if it's, say, low at like 5 or 10%, leave it in there. 5 and 10 is still good. And so you may see an abdominal x-ray of a patient see 3 kidneys. That's because we've added a third one to make up for a failing one. Now, the gold standard we're aiming for is kidney growth. We would love to grow new kidneys. We simply can't. It's too complex. You saw how complex that nephron was. We can grow the cells. We don't have the skill to grow them into those little tubes in the right order. We're doing a lot of work on that. When someone figures out how to do that, they're going to make $1 trillion and get a Nobel Prize. So there's a whole lot of pressure to make it happen. Right now, though, the big thing are 3D printers. There are a couple of groups who have been able to design a little plastic polymer kidney, not that big, that can filter out, it functions about as good as like 2 or 3% of a normal kidney. Well, okay, if you're big enough that I can implant 10 of those, that's 20 to 30%. That's enough to keep me alive until a kidney transplant. And so these are still very experimental, but we're seeing a lot of good progress. And so we're working harder and harder to find good material that is not immune reactive, that is stable, and allows us to make them selectively permeable. And so that we can use them to create a synthetic kidney. We're getting closer. We're getting closer. It's impressive to see what we can pull off. All right. Couple of last little terms. We'll wrap up the chapter. I want to talk with you about renal calculi. That's the term for kidney stones. Kidney stones. Kidney stones come in 2 types, casts and crystals. Casts are organic. They're made of cells and proteins. They're going to be like mud. They're going to be very smooth. Crystals are inorganic. They're made of minerals and salts, very pointy, very stabby. As they pass through that ureter, they're going to scratch and bleed a lot. Diabetes, we talked about diabetes before. That's going to be that polyuria. There's different types of diabetes. And so we're not going to worry about knowing the different types now, but eventually when you do cover more on things like the endocrine system, you will learn the difference between diabetes mellitus, diabetes insipidus, and gestational diabetes. All these are very, very different. You will eventually know these. For now, what you need to know about diabetes is that it causes a lot of polyuria. You pee a lot, which will make you very low blood volume. Finally, we get to the last phrase, that's urinary incontinence. That is a loss of micturition control. Urinary incontinence refers to a loss of micturition control. You're unable to control when you release. This could be due to anatomical trauma to the urinary sphincter, to the urethral sphincters. It could be due to hormonal signals. It could be due to spinal cord trauma, a variety of things that are preventing the urinary system from properly controlling when you pee or not. There you go. There's the chapter. A lot of material. You're going to spend a lot of time working on this stuff. Take your time. Make sure you understand it properly. Let me know if you have any questions. Good luck.